Hi, my name is Lauren Perlman. I'm a respiratory therapist for the CAPE and Home Ventilation Program at Boston Children's Hospital. Today we're going to review the use of the Newport HT50 ventilator. Newport does have an HT70 and 70 plus ventilator, but today we'll be talking about the 50 ventilator, commonly provided here in Massachusetts from our durable medical equipment vendors. Here is the ventilator. It is approximately 15 pounds. It has approximately a 10-hour battery within it, which makes it quite desirable by families in the community. I urge you to please test your battery on a regular basis, run it at home on battery so that you can assure that you actually get the 10 hours out of it. If it needs to be changed out, certainly that can happen as well. The face of the ventilator is covered by this panel. This is where the settings are for your child. Here are a little bit of information from the ventilator company about the settings and alarms. On this side of the machine, we have the gas outlet where the main flow of gas comes to give your child breaths. We also have two adapters that need to be connected to hoses on the circuit. One is labeled airway pressure, and that will be attached to the pressure line, which we'll show you in a moment. The other one says exhalation valve, and that will go to the exhalation valve where your child exhales air out of the circuit. The other side of the machine here has the power connector for when you're not on battery and you're charging the battery or running off wall power. The gas inlet is here. When you look in there, it's kind of hard to imagine that air does go in this hole, but if you hold a tissue to it while it's in operation, you'll see the tissue being pulled in. If you remove these three screws, what you'll find is an inlet filter. So periodically, per your durable medical equipment company, please do check and change the filter. It should be white. This is where noise comes out of the machine, so please do not block the noise port for where you'll hear your alarms. The rear of the machine may or may not have these hooks. This would make it obviously easy to hook on the back of a wheelchair, for example. The most important take-home message today about the Newport HT50 ventilator is that to turn it on to ventilate your child, you must push the on standby button twice. You hit it once to view the settings, assure they're appropriate and/or adjust them, and twice to enable ventilation. To turn it off, again, twice to turn it off. And then you must silence the alarm so the ventilator understands that a human being has seen that it's been assured it's been taken off a person. Your child's settings on the ventilator can be viewed here under the cover of the front panel. The doctor will prescribe either a tidal volume for a volume breath for your child as set here, or a pressure preset breath, meaning that there'll be a pressure in which the ventilator achieves and your child will receive a certain size of breath based on the pressure that's set. You will see the number in this window. All of the parameters can be changed by using the arrows. You select the item and change it by the arrow. There is a lock feature, so the machine can be locked so that other little fingers in the household, etc., cannot change the settings. I'm going to push the button once. This means we can view the settings, but it does not mean that your child is receiving ventilation. So do not put a person on the Newport HT50 until you've hit the button twice to start ventilation. What we see here is it does tell us that. Press on to vent. And reviewing the settings in the front panel, we see P trig 0.6. That is pressure trigger. That is how your child initiates or turns on a breath, tells the machine, I want one, so the machine can deliver a breath into their body comfortably with their inspiratory effort. It will certainly give the prescribed number of breaths that the doctor has ordered, regardless of whether your child initiates a breath or not. But we would like to make the child comfortable if they're able to turn on a breath. This number will be adjusted for patient comfort. It is pressure trigger in centimeters of water. Some machines are flow trigger, so there are different numbers that we look at to make it comfortable for your child. There will be a little light that will flash when your child initiates a breath. We have the PEEP or CPAP setting. Right now you see it set on 6 centimeters of water. This machine refers to PEEP or CPAP, which is the end exhale pressure to help keep the lungs open between the breath cycles. It calls it P base. So in some of the reference areas you'll see P base, meaning baseline pressure. The pressure support set on this ventilator right now is 10 centimeters of water. So 10 is the dose or the amount of pressure support above the PEEP that your doctor has ordered for your child to help them increase and decrease work of breathing, but increase the size of the breath they take in between the mandatory breaths if your child's receiving mandatory breaths on the ventilator. If your child is breathing on just pressure support, that would be the support they receive. 10 of pressure support over the 5 of the PEEP level, or actually 6 in this case. I hope you caught me on that one. So that would mean that if we looked at the machine while it was running and we looked at the needle going up and down, we would see up to 16 and down to 6, up to 16 and down to 6 when the child triggers a breath on. And the lung inflation would depend on your child's ability of the lungs and the body to let air in. If they cough against it, they won't get much air. If the trach tube is full of secretions, they will get less air, and you might notice signs of distress, you might notice increased breathing rate, you might notice desaturation in your oximeter if you have your oximeter on at that time. So pressure targeted ventilation, whether it be the pressure support, which we talked about, which is a variation on BiPAP. So BiPAP, we talk about a mask on the face. When we talk about a trach to a ventilator, we call it pressure support ventilation. The amount has been predetermined before you went home, and certainly it can change over time. If your child has a cold or a respiratory illness, we may need more support, and if they're spending time off the ventilator, perhaps they're able to go to less support. Obviously, you discuss that with your own physicians caring for your child. In the red here, red sort of signifies an alert. We have a high pressure alarm, 35 centimeters of water. This is currently set at. That means that the pressure in the child's lungs will not exceed 35. Even if they cough against it, at 35 the machine will dump any excess pressure and volume and let another breath cycle happen. That will signal an audible alarm and a visual alarm. You will see and hear it, and it will call your attention to the fact that perhaps they may need to have their tracheal tube suctioned. We also see a low pressure alarm, typically utilized for disconnect, for example. This is set at 12 centimeters of water. So right now, our patient here, the needle should go up to 16 and down to 6, up to 16 and down to 6. So if it doesn't go past 12 because of a leak, the machine will tell us. And if it does go past 35 because they coughed, for example, it will tell us. Over here we see F. I'm not quite sure why they put F instead of breaths so that you could understand it more clearly, but that is how many breaths per minute this patient is going to receive of mandatory breaths that come no matter what. So this patient's going to receive 10 breaths a minute. The TI, or inspiratory time, dictates how long the machine will inhale those 10 breaths. So every 6 seconds, this machine is going to fire a breath, so 10 times a minute, 10 into 60, and then the inhale time of that breath will be 1 second. So 1 second in, and then time to exhale. And between the breath cycles of the 10 mandatory breaths that your child has been prescribed to receive, if they are on mandatory breaths, they can still utilize the pressure support for comfort to help them be more comfortable with the breaths they take in between the mandatory breaths. If they're asleep at night, for example, and the 10 breaths are more than enough to meet the needs of their body, they're not trying to talk, you may not see any pressure-supported breaths. They may just, what we call, ride the 10 breaths. If a lot of water builds up in the hoses, or they have a cup on the tracheostomy tube that's reduced quite a bit or perhaps absent, you may see the trigger light flashing a lot and the machine giving a lot of breaths falsely because it sees either the leak and is trying to achieve the pressure that we asked it to, or the water in the hoses is sloshing and falsely triggering breaths by the machine. So very important to keep the tubing dry from water, and also to be alert to the different states of your child while they're on a breathing machine and certainly while they're off. I ask all of my caregivers and family members to please note the child's heart rate and respiratory rate when they are awake and asleep and on and off the ventilator. So you know what normal is for your child, and you can help us discern when there is something that's not right, what it might be, by knowing what's normal and what's not normal. Moving forward with the settings, right now we have a light on that says volume. So this patient is going to receive 300, it says 0.3, so 0.3 liters, 300 cc's of air, 10 times a minute. It will blow in for 1 second. The patient will blow out, and in between those breaths, your child or my patient will be able to breathe with pressure-supported breaths. Some children, the rate is turned off, and they have just the pressure support. Over here, we have our modes of ventilation. This will be prescribed as well. You will learn this before going home. Assist control means that every breath will be the 300, and there will not be any pressure support. It will not be lit. You'll see if I change this to assist control, there's no pressure support. So for example, your machine malfunctions, you call your company, they bring you another one, they turn it on, perhaps something happens, the therapist has to run out, and all of a sudden you look and you say, well, I see the 300, but I can't give my child any pressure support. That's what it looks like when it's in the assist control mode. The most common mode is SIMV, synchronized intermittent mandatory ventilation. It means that those 10 breaths are going to come approximately every 6 seconds, but we want your child to be able to ask for it and turn it on and have it blow in when they're breathing in, not just fire by the clock. So if they're sound asleep, deep sleep, or just had some medication, it will fire every 6 seconds. But if they take a breath, it will deliver it during their inhale effort and make it more synchronous with their breathing effort. That's where the S comes from. And as it says here, this could have pressure support with it, like it does now, the 10, or we could touch this button and turn this off if we wanted to. So we have a choice. If your child is just receiving straight pressure support, no mandatory breaths, and or just CPAP, meaning assistance with the pressure in the lung between the breath cycles to help keep the lungs open, then you'll see the ventilator on what it calls spontaneous or pressure support. If we switch it once to that, we see that we no longer have breaths, a type of breath, an amount of time blowing in. We no longer have the pressure support because we had it on 0. So this would be considered just CPAP of 6. If I turn on by touching and using the arrow, that pressure support that we had before, this would now look like pressure support. You see this blank. It isn't because the machine doesn't care if it's disconnected. It's an internally set low pressure alarm. We don't choose it, the machine chooses it. We do, however, choose the high pressure alarm should there be a kink in the hoses, a cough, something in the circuitry that sends the pressure above 35 centimeters of water, or whatever is predetermined for your child with your family, your caregivers, your home nurses, your respiratory therapists, etc. For the purposes of today, I said 35. So those are the different modes, the way in which you set them, the way in which we choose different settings on the front of the machine. it would be like this running. Here it tells you that you can check the internal battery. If I push the button, it's showing me that my battery down here, you can't read it probably, but it's full. It says internal battery charge level, red up to blue. So this is a fully charged battery within the machine. Doesn't necessarily mean it's going to be 10 hours, which is why you should check that at home as well, because it may have lost its ability to take a charge. Up here you'll see lights for alarms with different symbols. If the high pressure goes off, the high PAW, high pressure light, will illuminate and stay illuminated until you reset it. There'll be an audible alarm for as long as that situation is still active. When the high pressure situation goes away, the light will remain on. So if you leave the room and come back and you heard a beep, you can see what went off, but perhaps it was reset because the child coughed once and that was all. We can see a low pressure alarm, which typically would be disconnection of the circuit. Device alert would mean that you would be taking this out of service using a hand ventilation bag or your backup ventilator if you have one, and calling the company to have it replaced. Over here we have high VI, which stands for high minute ventilation alarm, and low minute ventilation alarm. Minute ventilation is a mathematical term for how many breaths a minute multiplied by the size of the breath. So right now, if we went back to the SIMV mode where we were before, if our patient was sound asleep and the machine gave 10 breaths and they were 300 cc's each, that would be 3,000 cc's in a minute. The machine's going to read that for us in the parameter window, which I'll show you in a few minutes. And we have an alarm down here that we can set below 3,000 so that if your child isn't receiving the amount of air that you expect them to, the ventilator will alarm low minute volume based on the setting. So we have to set, right now we see high minute volume at 15 liters, and we see low minute volume at 0.5 liters, a half a liter. That's a wide range. We can narrow it based on what your child's needs are so that it keeps them safe on the ventilator, but also isn't going off like crazy when they roll over in bed and take a few extra breaths. What I'd like to do next is put hoses onto the machine to show you how we connect them. We have both the dry circuit that you use when you go out of the home, or if you're just using the HME or heat moisture exchanger. Some young adults and adults only use the heat moisture exchanger to their tracheostomy tube and to their ventilator. They do not necessarily all use the humidification system. Smaller tracheostomy tubes, younger, smaller patients, we do recommend that they use heated humidification. Larger tracheostomy tubes, larger, older patients don't always use the humidification. They rely on the heat moisture exchanger to capture heat and moisture when they exhale through their trach tube and provide it to the air that they breathe back into their lungs. It's dependent upon each healthcare professional's thought process for your child, the size, secretion thickness. Patients with very small tubes and very thick secretions will likely do better with the heated humidification system, and those of adult size, perhaps not. I have patients who tell me that they don't even want this because it soaks them. And I'm like, well, there's no water in the system anywhere, but their tubing gets very wet from their body. As long as the trach tube is safe, no history of it plugging with secretions, no issue suctioning secretions out or coughing them out, then this is effective. These are used by children and adults throughout the day for attendance of school, social functions, etc. when you want to be portable and away from home and away from the humidification system that is cumbersome to take out with you. They come in a variety of sizes. Before we move on, let's talk about the sizes. They come in a variety of sizes. This would be a mini for an infant, and it states on it how much air the size of their breath is and what would it best be used for, what size infant. This is also an adult one, but there are much larger adult ones. So the larger this is, the more efficiently it's going to provide capturing the heat and moisture from your breaths and giving it back to you. The problem is, or the concern or consideration, is that this is where the fresh gas comes from the machine and out the exhalation valve, from the machine out the exhalation valve, and you breathe from here. So the more pieces we add on to our circuit, you know, we can make this very long with all kinds of pieces we have, but your child or adolescent or infant has to rebreathe air the longer we make this from the fresh gas source to the tracheostomy tube, for example here. So we don't want patients to have to rebreathe this volume of air. It would mean that they would have to breathe harder. So we don't want them to breathe harder because they have to breathe through all this extra, what we call dead space. So we have adapters that are appropriate for infants of small volume and adults which are larger. We have the heat moisture exchangers for infants and for larger, and they come much larger than this. So you really don't know. You may possibly get a shipment that's incorrect to your home, and you might think, wow, this looks great. This gives us a lot of space for our child to move around and away from the ventilator, but it isn't appropriate. So please be on your guard for things that come to your home that aren't devices you've been using that have been approved by your healthcare professionals that you're working with. Let's review the patient circuitry. In the package, when your circuit is opened, this is called the J circuit. It is the most common and comfortable circuit that comes for the Newport HT50 ventilator. It will come with a short piece that will connect from the gas outlet to your humidifier if you are using one. And then it has a piece which, for our purposes today, is a little bit short, but it does come longer in the package. Takes the air out of the humidifier after it's been heated and warmed and takes it to the tracheostomy tube. This is the exhalation valve we mentioned, so the patient breathes. The gas comes here into the patient and goes here out through the exhalation valve. This controls the pressures, the volumes, the PEEP, the time. So the settings on the machine, this is where the machine gives input for what the machine should do. I should close and fill the lungs for 1 second, and then I should release and open. I should hold a little bit of pressure there because you told me you wanted 6 centimeters of PEEP. So it's important to have everything connected here. There is a pressure line that goes to the machine as well. The machine recommends that you use a filter, and they provide these, not in the package with your circuitry, but additional pieces. This filter will go onto the pressure line. Hard for you to see, but there's a pressure line here. And then we talked about the exhale valve. So there's a little hose. If we follow it, it goes to the exhalation valve. That connects here as well. And then again, we have the gas outlet. We have a choice when we open the package whether we would like the pressure line to go all the way back to the machine from up here, or if we would like to remove it, cover it, because it is a hole, and put the pressure line back into the circuit. Remember, we have the filter for the pressure line. We can connect it back here also. The reason why people do that is because if you have the circuit with water in it, and this is connected to your tracheostomy tube, and you do some rolling around when you're sleeping and moving around during the day, a lot of water can go in the hose and cause the machine to give you a lot of alarms and also put water into the filter. That's why the filter is present. So some people will, what we call, bypass from here and put it back at the machine. So either way that you were taught, that's what you'll do, obviously, when you go home or at home. And if you have a lot of problem with water in the hose, consult with your respiratory therapist and your physician about different configurations that may help you. Perhaps you're not using a humidifier, so it doesn't really matter, but you find that another piece of tubing up here is heavy, and it's one more thing to pull at the tracheostomy tube. We'd like to reduce chances of dislodging the tracheostomy tube, so this would be attached here. Since this is adult tubing, I'm going to put the adult adapter on it, the one that holds larger volume. The Newport HT50 in our area here in New England is typically utilized for older children. It does have larger adult ventilator circuits rather than smaller neonatal circuits. It does have some features that are not available on this particular model, the HT50, although are available on the HT70 and 70 plus ventilators to aid young, weak children, infants with small tracheostomy tubes to breathe comfortably onto it. So there may be different reasons why you see other children of different ages with different machines and you wonder, well, why don't we all have the same thing? They don't all do exactly the same thing. This one I personally tend to use for older kids. It has the wonderful long battery life inside it rather than having additional batteries. It can be hung on the back of a wheelchair for those that are going out to school or out for social events. So this would be a configuration. The gas comes out, it gets heated and humidified, it goes out to the patient or child, and they exhale through the exhalation valve. Both the pressure tap and the exhalation valve are connected to the device, and right now it says press to on vent. Remember, 2 pushes to get this to start ventilating a person. So we're going to hit it on again. And now we're going to see the needle move. We're going to see here pressure trigger light up when I initiate a breath from the machine. Now I could be initiating one of the 10 breaths that delivers 300 cc's of air, and I could be initiating a pressure support breath. Well, how am I going to tell the difference? How are you going to tell the difference? Well, we know that this breath has been told, I want to give 10 of help over 6 of PEEP. That means the top number over here should be approximately 16 for that breath. And if we watch the needle, it should be going to about 16. If your child's at a party, coughing, excited, trying to talk, the numbers are going to vary quite a bit. But during sleep and calm times, we should see around 16 for this one. And then whatever amount of pressure it takes for the 300 cc's to be delivered into the lungs. That's where those normal numbers come in. I'd like you to know what the pressure or the peak inhale pressure, the PIP, is for your child when the ventilator pushes in those 300 cc's. Let's, for example, say it's 20. Well, if tomorrow or the next day it's higher, why is it higher? Is there a blockage? Is the tracheostomy tube filling with some secretions? It's important to know if the machine's having a harder time blowing the same amount of air in. Now, we do have balloons or cuffs on the tracheostomy tubes. Some children have them and some children don't. So the numbers will vary awake and asleep. They'll vary with the cuff up or cuff down. So it's really important to get to know your own child and what their numbers are and what they see. In the window here, the machine gives us a couple options for numbers. We can look at the size of the breath and how many. So this tells us that the breath size is that one, that last one had said 300, so around 300. We've asked for 300. So what you're seeing is some of the breaths are like 300. Those are the ones that we're sending 10 in. And F, remember F is 10 breaths per minute. F is 14. So that's counting how many breaths a minute your child is receiving from the machine. So 10 of them are those preset 300 cc's of air has been determined to be the right amount for your child's body. They fire 10 times a minute. And in between those breaths, your child is taking some more breaths, and they're using the pressure support. So this is total respiratory rate. These are measured parameters. They're measured here. They come out of the machine. It's what the machine is sending out. Some machines measure what comes out of the patient. Some machines measure what goes into the patient. So these are all what we call inhaled numbers. We talked a little bit about minute ventilation. So the machine is looking at how many breaths and the size of them. We talked before about looking at these numbers. If I want to blow in 300 cc's 10 times a minute, that would be 3,000 cc's in a minute. We're looking here, our VI here, which matches our VI up top, says 4 liters a minute. But we know our patient is taking more than the 10 breaths. We see 13, 14 breaths. So 4 liters a minute is what? And actually down here it's more defined. 4.4 liters a minute is the actual amount of air in a minute that our child here is using right now from this machine. If our child breathes faster, okay, now our child's breathing 16, 21. Our child's breathing faster, and the amount of air has gone up from 3 to 6 liters. So if your child breathes faster and more air, the amount of air in a minute they're utilizing for their body will go up. And if they slow down, it'll go back down to baseline. The alarms are around this. This is a dual button situation here. It has little red bells on it, and it says VI low and VI high. So 6.7 is the number, the actual number it's reading right now, but if I hold the button down, it flashes. So half a liter or 0.5 is the low alarm setting, and 15 is the high alarm setting. This is the way it was designed. So when it's not flashing, you're seeing the actual amount of air in a minute that the machine is sending to your child. And if you push the button, it flashes, and those are the alarms, which can be adjusted again with the arrow. Everything is adjusted with the arrow. But as we talked about earlier, it can be locked with an internal menu, so that you would hold the button for 5 seconds to unlock it and be able to utilize a change. It's pretty quiet, although I will say sometimes when this machine is disconnected, it can, depending on the cycle and when it's taken off, it can sort of sputter like a jet plane taking off. But you're not really seeing that today. So now you're seeing that we have a low pressure situation. I've disconnected it. We have a low pressure alarm. I'm going to reconnect it so that I've reset our alarm. Okay, you walk back into the room. You heard an alarm. You no longer hear an alarm. But you see, low pressure went off. What are you going to do? Well, the child's fine. So something must have happened. Maybe they yawned and the pressure wasn't met, but you see everything appears to be doing very well. You come over and you reset the button. So now the lights are not on anymore. So when an alarm happens, you'll hear it, you'll see it. It will reset itself if the condition is reset. Certainly if the child falls off, disconnected from the ventilator, and it's not put back on, you're coming into the room. You have to reconnect your child to the ventilator and reset the alarm. What I'm going to do now is I'm going to push this pressure control button. I hit it once. It tells me that the peak inspiratory pressure is set for 25. I'm going to hit it again to change it. So now we've changed our ventilator settings to pressure control or pressure targeted mandatory ventilation and pressure support. That means that 10 times a minute, our patient now will have a breath delivered that achieves a pressure of 25 centimeters of water, and we can see that here as well. It'll inhale for 1 second and then release. If I initiate breaths, you'll see the trigger light go off. So that tells me that I'm initiating breaths and it's firing. Some of them may be up to 25 and down to the PEEP of 6. Some may be up to 16, the 6 plus 10, and down to 6. You would expect that if the pressure for the 10 breaths is much higher than the pressure support breath, the size of those breaths may vary as well. So you may see a larger breath for the pressure control breath of 25, and you may see a little bit lower for the breath that goes up to 16 with that 6 of PEEP. I'm going to go into this area again. Let's reset our alarm and let's go into this area. So we're going to look at the volumes on this particular mode. What we're seeing is that with a pressure of up to 25, we're getting some large breaths here. And then we see some smaller breaths. That's a combination. We're seeing the larger breaths when the machine is inflating the lungs to 25 centimeters of water, and some smaller breaths when our person is using the pressure support. And again, it's multiplying this number by the rate to give us the amount of liters, 7.3, 7.7 liters a minute, that are being utilized by the ventilator right now by this person. I can push the up arrow again, and I have a choice of pressures that I can look at. So we have 3 screens here that are being information fed back from the hoses to the machine. We can look at the pressures, we can look at the volumes and the breath rate. We can have it blank if we so choose. Right here we're going to see the pressure, which is, we've asked for 25, it's measuring 26, 27, that's within range. The mean pressure tells me overall how much support this machine is providing for your child. Nothing for you to set or adjust. And then we have our baseline pressure, or PEEP, which is set here. It's set at 6 and it's measuring 6. So we have the peak pressure, the mean pressure, and the baseline pressure. This one we've set, and that's the measurement. So if I take us back to volume, let's go back to, we had 300 cc's of air going in 10 times a minute. We talked about if the trach tube had some secretions in it, perhaps the pressure would be higher to deliver that 300 cc's. We've gone back to SIMV, volume control breaths with pressure support. The machine is going to blow in 300 cc's of air as best it can with a limit of a pressure of 35 centimeters of water, as observed here as well. And the machine also looks at the P, the peak airway pressure of the breath. You can see that they're low. What if the trach tube is blocked? We see high pressure in the window. We see it popping off at the 35 we've asked it to, and we see the high pressure alarm illuminated. We also had an audible alarm. So this situation may reset because the child coughed and turned, but if in fact the circuit was plugged and the trach tube was plugged, when the machine tries to blow in the 300 cc's, it cannot, and this alarm is going to continuously go off until you address it. So having an actual amount of air, a volume breath, set for a patient on a ventilator is a nice safety net, so that if the air can't go in, the machine's going to tell you immediately by giving us a high pressure alarm that it can't get air in. That's not the same as the pressure targeted breaths, because the machine has been told to go up to a certain pressure and release. But we do, for that reason, have our low minute volume alarm. So it's important to have all the alarms set as appropriately as you can. You may have to change them for nighttime and daytime, because daytime people like to talk if they're able to. They want their cuffs down on their tracheostomy tubes if present, and they actively want to speak. At night, we relax. If we don't have a cuff, we're certainly going to have more leak out our nose and mouth, and that might throw the ventilator off a little bit. And if we put the cuff up a little bit, not too much certainly, we want what's called minimal leak technique. So we just put enough water or air in the cuff so that we don't have a lot of gushing out the nose and mouth of air from the ventilator, because we don't want to put pressure on our trachea inside. Let's now show you a different circuitry. Very simply, if I want to go out, all I'm going to do is bypass the humidifier, so that, let me give us a silence on our alarm. We can actually go into standby. So see, it says press again. I pressed it once. It's no longer, it went past. Sorry, it didn't want me to. Okay. So if I take the main gas outlet off the humidifier and put it onto the ventilator, so now the humidifier is staying behind. We no longer need that. We're going to put our gas outlet. We will need an adapter for our pressure line. Our gas outlet to the main outlet. We'll reconnect our pressure line. And now we can exit the home with just the ventilator and this short hose. You can see there are areas here where you can cut it. So if your patient's in a wheelchair when they go out and you don't want long tubing draped, you can cut it short and make it appropriate length for them. I cut it short just for the purpose of today, so we didn't have a lot of tubing draping around. So this would be an adult non-heated wire circuit for travel outside the home, for use in the home if you're going to use the heat moisture exchanger. If you're going to use the heater, if we don't use heated wire hoses, there is a hose with a water trap in it that we can have the water be dependent and drain into a water trap that we have to empty. That's another option. So we can have what we call the dry circuit for travel. We can add the heat moisture exchanger. That could be 24/7 for a larger adult adolescent patient who has a larger trach tube and doesn't have a problem with thick secretions. We could move next to a humidifier with a water trap in the hose, which means you have to drain it. And then the Cadillac would be that we actually change this hose here to one with a wire in it. So the company would send you another hose, and it's blue, and I'll show that to you in a moment. And then we actually hook it up to the humidifier, and we use our probes and our wires so the humidifier can communicate with the circuitry and keep the humidity appropriate level so it's not causing a lot of extra water in the circuit. What I didn't talk to you about yet was oxygen. There are a couple different options for oxygen. The company makes this. This, believe it or not, goes upside down, and it goes onto the place where I told you air goes in from the room to the ventilator. So this is an air compressor. This makes air. You do not need oxygen if the child is not prescribed and does not need oxygen. If you do, this is the reservoir that goes onto the machine, and it has an adapter to place oxygen tubing to go to your oxygen source, whether it be a home concentrator, home liquid system, portable concentrator, tanks, whatever your source is. The prescribed amount of oxygen will be based on your child's needs. Everything in the home care world comes in liters per minute. So unlike in the hospital, when your child might have been on 28 or 30% oxygen, at home we look at the oximeter, oxygen monitor, and determine how many liters a minute into the ventilator achieve the goal saturation that your child has been ordered for by the physician. Typically above 92, below 98, somewhere in that range. Oxygen is a drug. Too much isn't good for you, and obviously not enough isn't good for you either. Some of the companies will use other adapters, such as this little piece here. They might add a T and put oxygen right here at the outlet of the machine. It doesn't really afford the machine the opportunity to mix the oxygen with the air before it comes out, but it's still adequate and will provide oxygen mixing with the air from the machine for your child. Others will use pieces like this to stick on here. Most of the homes I go to, I don't see the Newport adapter, and I'm not sure if it just over time sort of comes apart and pieces move around or the bag breaks, or it is a little bit cumbersome, as you can see, to go out and have that hanging off your chair. So some people do use other adapters on the air inlet or here on the outlet. So one or the other, that's where you'll provide oxygen to the ventilator for your child in the liters per minute prescribed that achieve the saturation goal that your doctor has advised you to look for your child. Okay, now we're looking at the Newport HT50 with heated humidifier and heated tubing circuitry. So we've replaced the white dry circuit without wires for one that does have a heated wire within it. And now it is communicating with the heated humidifier. This particular one is Fisher-Paykel, but your company may provide you with a different brand. Nonetheless, the cool, dry air is coming out of the ventilator, going through the humidifier chamber, picking up heat and humidity, and coming out to your child. Then they exhale through the side that does not have heated wire in it, so there will be moisture for sure here and moisture coming out the valve. Remember not to block this. This is where your child exhales. You'll see we have some permanent wires here and adapters into the circuitry. That allows the humidifier to look at temperature both coming out of it and the air temperature up near your child. This is where we've prescribed we would like near body temperature here. So this is the tubing that you want to be aware of, to have condensate but not puddling of water. We don't want puddling to shake it and cause the machine to do false breath initiations, or we call auto-cycling, because it will give the child breaths and potentially hyperventilate them. The Newport HT50 does provide backup ventilation for those patients that are not on a mandatory rate in which the rate's going to come along anyway. For example, if your child's on CPAP or pressure support and doesn't have a mandatory rate, what happens if they stop breathing? Some of you know the word apnea. This machine actually looks at low minute volume as a reason to give more breaths. So what it looks at is the amount of air. We've talked about minute volume. Right here we see 11 liters a minute is what our patient is breathing right now, and our low alarm is set at 2. Up here you'll see low VI alarm is hooked up to backup vent. So if I raise our alarm past the 11, the machine will think that we're not breathing enough and go into what's known as backup ventilation. Low VI, or minute ventilation, backup ventilation, flashing and alarming. And what it does, it has automatic settings that it goes to. It doubles certain things when it senses that the patient isn't breathing enough air that you asked it to alarm for. So that is backup ventilation. It's preset, with nothing for us to adjust. It's based on the numbers and the settings that your child is on. But it does alarm to tell you that. So if it's saying BUV, backup ventilation, that's a low minute volume alarm, and the machine is now firing mandatory breaths. Let's review the alarms on the HT50 ventilator. We have high pressure alarm, currently set at 35 centimeters of water, which will audibly alarm if the pressure in the circuitry and potentially in your child's lungs reach 35 centimeters of water. It will audibly and visually alarm. It'll reset itself if the condition, like one cough, goes away immediately. We also have the low pressure alarm, which currently is set at 12. If the 12 is blank, it means that in that particular mode on the HT50, it's preset by the machine. There's always a low pressure alarm. We have the low and high minute volume alarm, they call VI. We can observe the minute volume currently. We can also observe the alarms by hitting the button to look at what the high and low are set. The standard would be half and twice what you see your child moving for minute ventilation air. We would set the alarm half and twice that to be safe. If the child has an uncuffed tracheostomy tube or the cuff is deflated, for example during the day for speech, we may need to adjust those alarms. Typically children, when their cuff is down and it's daytime, they are attended by other people caring for them that can watch other parameters. You still will have the high and low pressure alarm if you are somewhat disabling the minute volume alarms. We have the BUV, backup ventilation, which you just saw enabled when the child breathed below the amount of air the machine was told to alarm for. We have device alert right here. If that's lit, we're going to pull it out of service, use our hand ventilation bag, call our company, use our backup ventilator if we have a second one in the home. Typically, children that are on ventilators only at night have that machine only. Children that are on the ventilator for 24 hours a day will likely have 2 machines. We also have an alarm which you haven't seen today because we don't have water in our circuit here, but it's called check prox line, and the machine doesn't like it when the machine has a problem with its pressure line. And if I kink our pressure line, we'll likely see that in just a moment, but it'll say check prox line. Certainly in the manual that you get with the device, you can look at all the different alarm pages, print some of them. We have some easy cheat sheets that I've prepared for our families here locally to use to post on the wall when they have their children home on ventilators. And you see here the check proximal line. It didn't like me crimping this line here. So there are many alarms, some that you see here on the face, some that are internal. Please become familiar with all of the alarms that you may see on your child's ventilator so you know how to respond to them. And certainly, when in doubt, use your self-inflating bag with or without oxygen based on your child's needs. It's important for you to understand your child's ventilator support and have that with you just like you do a medication sheet, for example. If you're at the doctor's office or going to the hospital, perhaps by ambulance, Or perhaps you have an appointment during the day and your child's on nighttime support and you don't have the ventilator with you. It's important to know what it's set on. So either jot it down somewhere, or if you have a smartphone with a camera, take a picture of the machine while it's on your child so that you can show the providers at the local facility that you go to what the settings are for your child. As far as cleaning the equipment and changing the ventilator circuitry, etc., the ventilator should use sterile water in the humidifier if you're using humidification, and refer to your durable medical equipment company for how often to change the circuitry. Typically it's twice a month or every other week. I hope you've enjoyed this video. I hope it has helped you to understand your child's Newport HT50 with regard to the settings and some of the nuances of water in the hoses, for example, and what auto firing or auto cycling means when you see the trigger light going off frequently. Please do ask questions whenever anything seems to be out of the ordinary for your child in the home.